So I'm going to give the trauma lecture today. You might have noticed, but I'm not Linda Russo. She's sick. She actually is so dedicated to the derm block that she has cellulitis. She can't be here today. So bear with me. These are her slides. I don't know if she completed them completely the way she wanted them to be, but we'll muddle through. So we're going to talk about burns a little bit, and there were no acknowledgements. So we're going to focus on thermal burns, general pathophysiology, and we'll go through some cases and just talk about some salient treatment pearls. So general pathophysiology, and this is kind of, she took this just as a review. We have the center zone, so this is where going to be the zone of coagulation and necrosis. This is really going to be the focus of the most damage and really not going to have much reversible damage here. And kind of like a lot of other ischemic processes, you can have an ischemic zone where you can have some decreased microcirculation and you can have some healing there. And then you have the hyperemia zone, and you guys have seen burns, surrounding kind of the area of the burn, you have this inflamed hyperemic where a lot of the inflammation and cytokines are, which is where some of the healing starts and some of the inflammation is going on. She drew this document. I'm not 100% sure where she was going with it. I'm sure she did spend a lot of time on it. Yeah. So I mean, basically, we're talking about the inflammatory area here, where it's going to be all the cytokines, the apoptosis, and this is our immune system working, but at the same time, the inflamed skin, inflamed tissue can be susceptible to infection, and you have free radicals. All right. Case one. So you have a gentleman. He may be Irish descent. I've had this many times. Out in the sun too often, too much, and has sunburn. And yes, I have seen people come in with into the emergency department with these injuries. So, what are the things you want to consider? Sorry.
The depth and the extent.
Okay. What are we dealing with? What do we think this is? Yeah, so superficial, right? This is just going to be involving the epidermis, it's more commonly called a sunburn. And how do you want to treat these patients? I heard analgesia.
Topical.
Yeah, just topical supportive care. A lot of times they can have some dehydration. Sometimes it's associated with alcohol intoxication. So be aware of that. And you can have a lot of your chronic alcohol abusers come in with superficial burns like this. So now we have case two. Similar kind of presentation. The person was out in the sun for too long, but now we have some other findings. So I think the big question here is kind of the difference between superficial and kind of your partial thickness, or quote unquote second degree. And I don't think Linda was covering this, but we have kind of the antiquated nomenclature of first degree, second degree, and third degree. A lot of most of our burn colleagues don't use this nomenclature anymore, so it's a good idea to get more familiar with the superficial, partial thickness, full thickness kind of characteristics. So our superficial is just going to be that in the epidermis, and our deep is going to start involving the deeper tissues, the subcutaneous, and this is where you're really going to start seeing blisters. So kind of some of the controversial topics here. What do you want to do with these blisters? Sorry?
Depends on who you ask.
Right.
Yeah.
So does anyone know kind of the controversy or the recommendations?
Yeah, pop or not pop.
Right.
That's the question, but I think I would not.
Okay.
I would
Anyone have a different opinion? Faculty, you guys?
I just read open ones, and then keep intact ones intact.
Okay, so intact, keep it application?
It depends where it is. If it's over a major joint, you don't want to limit the mobility of the joint, so you might have to drain.
Okay.
That's the case with water on them, toothpaste, lard.
Recommended or not recommended?
Shy away from that. It's not a meal.
Dr.
Just
Gershon?
back up first real quick in this. But you know, one thing I think is very useful with sunburns before it gets to the second degree is I found very useful non-steroidals and also hydrocortisone cream. I find that's very soothing. You gotta use a lot of it. As far as this goes, I agree with Mike. If it already is leaking, then you definitely should further open it and, you know, clean it off and really cut it open. Or if it looks like it's very thin, it's going to break at any moment, then you can. I think if there really is in a safe position where it doesn't look like it's going to break and it's not leaking, I would leave it alone.
So, kind of for the, maybe people who aren't as familiar.
Bill, I just had a question. So for if you are going to open it, do you like to leave the epidermis on as like a natural bandage, or do you like to remove it and use an artificial bandage?
I like to leave the skin on. I think that's the best barrier that you have. So if you can keep it intact and leave it on and then bandage over that, I think that's the best thing to do.
I put a couple of needle holes in it, or a sterile needle, and leave the skin on. That's what I always been taught to do for real out.
So the controversy comes from two kind of factors. One is that there's the idea that in the blisters you have a lot of cytokines and inflammatory mediators, so that can increase the chances of a contained infection. So one kind of way of thinking is to pop these, debride them, and they think you should debride it completely. There is the other thinking that kind of what we kind of just touched on, was that the skin is the best barrier you have. You don't want to open that up and that can cause more infection. So obviously there hasn't been like a specific study done to look at this, but the things that you heard here are kind of the general recommendations. If it's tensile, if it's going to pop on its own, you think shortly, it's recommended to do that in a controlled setting in the ED or the hospital, because that might as well happen there where you can bandage it and cover it, rather than at home, who knows what happened. And if it's already open, then to complete the debridement and to make sure that it's washed and cleaned and covered. And other than that, it's kind of really what your general practice and preference is. Okay, so we kind of talk about this ad nauseum, but it's something that always shows up on the boards, on the in-service, as well as in practice it comes up. So basically just knowing the general body surface area characterization of how you're going to classify a burn. For pediatrics, there is this London Browder chart where you can have different percentages for different ages. I think for pediatrics, a lot of times it's easier to use the palm of your hand 1% rule as well. That's kind of a good rule of thumb. Any questions on this? And then for more severe burns in general, you're always going to think about your ABCs, IV fluids, IV pain control, and then fluid resuscitation, again, another thing that we talked about a lot, and it just shows up on tests and in management is important, the Parkland formula. So it's just a formula that you should memorize, and the big thing to remember that the half of the calculation is given in the first 8 hours, and the remainder is over 16 hours. And this is from time of onset of the burn. So if this is a delayed presentation of burn, you have to make up time if you're catching up. So another EBM question Linda had here is, what about colloid use? And well, first of all, what kind of crystalloid are you prefer to use with burn resuscitation? Yeah, for the most part, lactated ringers is recommended. I think if you're in the ED and you have normal saline and you want to start the resuscitation with that, that's fine. But if you're giving these large amounts of fluid, then you want to think about lactated ringers for things that we discussed in the past. How about colloid use? Albumin, some of the synthetic colloids. Anyone seen anything about this? Yeah, there's really not great data. There's some, I think 1 or 2 studies that looked at albumin, and there was less overall fluid given, so that was preferential, but there weren't large enough studies. And then for the other ones, like the gelatins and the HES, there was actually increased morbidity, so they're generally not recommended. And then how does the Parkland formula do in general? It was developed, I think the date was 1968. So is this something that is just kind of one of these other traditions of medicine that's out of date, or is it something that actually holds up? I hear a lot of
Fluid recess in burns is kind of something that is important because a lot of patients get either over fluids or under fluids, or either of those kinds of things can lead to badness. So it's really more about monitoring like urine output and just getting the right amount of fluid per area and how the patient themselves are.
Good. So that's a good thing to keep in mind, that you're not just going blindly by numbers, that you want to look at the patient status and how they're responding. There was some small studies done on this. In terms, I think the initial one showed that Parkland actually under-resuscitated burn patients, and then another one showed that it was pretty much on point. But I think what Ned said is pretty accurate. You kind of watch these patients, watch their fluid status, and that's what's going to be happening with them in the burn ICUs. And we all know now that fluids is not a benign process and shouldn't just be hanging on anybody.
It's a good start, but the best thing to do is follow the urine output.
We talked about a lot of this. So just kind of like what we talked about with superficial burns, but these patients are going to have open wounds most of the time. You want to put some sort of topical antibiotic. Silver sulfadiazine is the classic kind of recommendation. But I think Dr. Zatopsky actually did a study comparing these and showed that there wasn't a significant difference between using silver sulfadiazine versus like a bacitracin or a Bactroban. Dr. G?
So if you're gonna use sulfadiazine on, don't use it on the face. It can cause hyperpigmentation. Bacitracin is much better on the face. In addition, if they're allergic to sulfa drugs, you can't use any of those, sulfamide, silvadine. And finally, if they have a very large denuded area, they may absorb too much if you use the silvadine. So those are some things to think about when you're using it.
So it also can cause some pigmentation changes, so you have to be careful if you're going to use it above the crowd.
For Dr. Rockwell that he did for me, in peds they actually have like the biogels that are impregnated with silver, which is nice because for kids and for people we don't think are going to have adequate wound care at home, they're not going to change dressing, they're going to leave it on for a week or two, it's easier for them. And these are the outcomes. There's no real difference between them except how much they comply. It's if you're in peds, they have it in there and they go to the backwards. And the hyperpigmentation is not something you have to tell them about, but it does eventually go away.
Good. So that was kind of Linda's point here in terms of using these commercial occlusive dressings. They can be left on for a longer period of time, and you want to consider people who aren't able to do wound changes and things like that.
One of the nice things to do for outpatients is order it from the Pyxis and put a layer on the patient and then give them the tube. So you don't have to worry about them paying for it and getting it, at least for the first couple of days. It's just nice to do.
Yeah. And just remember to consider facial application of silver sulfadiazine, and that there is really no big difference in between using that versus other antimicrobial topicals.
Yeah, I thought there were some studies showing that it did worse in partial thickness. So because it delays healing or something.
I'm not sure. I'm not aware of the study, but I think it is falling out of practice.
It kills fibroblasts is a theory they have. It's not confirmed, but I heard it recently.
So do we give these guys, other than topical antibiotic therapies, should we give these patients antibiotics, systemic? No. Starting diabetes, I heard no. So generally the answer is no. That you're really not dealing with an acute infectious process here, as long as there's good wound care, including the topical antimicrobials, and you have good debridement. These patients don't need antibiotics up front. When you're dealing with delayed presentations or patients who might be following them for a long period of time, then that's something you can consider. But even in like one study, it was Linda looked over that in third world countries where wound contamination is higher, more of a risk. It wasn't recommended, and you had higher antibiotic resistance. So you're just adding to the problem. There's a classification of burn severity. I'll leave it up there for a minute. I don't want to go over it in depth or ad nauseum, but just be aware that for children and elderly population, that a lower percentage is going to classify them as a higher severity when it comes to moderate. And then pretty much any full thickness burn over 2% is going to be something that you want to take seriously. That classifies admission or maybe get to a burn.
Is this again partial thickness or is this all burns, all comers?
This is not partial thickness. This is total body surface area. But when you're considering body surface area, you're not really considering superficial. That really shouldn't play into your factors. Partial thickness to full thickness. Yep. And then they just have special classifications of any full thickness. If you have electrical, inhalation, or circumferential, you should consider. So case 3, now we're dealing with the severe burn patient. So again, you want to think about your ABCs, your IV fluid resuscitation, monitoring, pain control. I think anyone who looks like this, you're gonna want to intubate them, even if they're not showing signs of inhalation injury, even if they maybe not necessarily have this neck injury. These patients are going to be in a lot of pain, and they're definitely going to the ICU, and they're critically ill. So it's just like somebody with multiple long bone fractures or someone that you know is going to the OR. You're probably going to intubate them up front so you can control the situation, and you can do the tests that you need to do and give them good pain control. So always this question of succinylcholine in burn patients. Anyone want to weigh in?
Depends on how long ago the burn was.
Yeah.
It's within like the last day or it's like multiple days. I think it's okay because the risk of hyperemia is more.
Yeah, exactly. It's something that I feel like we kind of learned, but hopefully any burn that looks like this, we're going to be seeing very acutely. It's really a non-issue. If you can use other medications like rocuronium if you want, but if it's the easiest thing and it's available, succinylcholine is fine in any acute burn. And what's the reason why we even think about this? Hyperkalemia, yeah.
Have you ever seen a case study of it?
Have I ever seen a case of it? No.
I've never even read about it, although I guess nobody wants to be the one to publish that case, but I've never even seen it.
Yeah, it's like injecting lidodepi in the finger or anything like that. We don't want to be that case. So in these patients too, you want to consider escharotomies. I'm gonna show a video on an escharotomy. I think it's something we don't see very often and should know about. But anywhere you can get in the extremities, you can get compartment syndrome, and then probably the most important to life-threatening is having a chest eschar that's causing restrictive breathing patterns. But I'll show a video on that. This is just informational burn centers in the area. These are mostly the ones I usually give the patients the option of Staten Island or Jacobi.
Yeah.
Yeah, they have a Brooklyn address for clinic.
Yeah.
For our
So on Coney Island Ave, it's Staten Island.
I think the outpatient is Coney Island, but if you're sending someone to an inpatient burn, it's going to be Staten Island North, on Staten Island.
They're pretty good. I sent somebody to a fast track with it, like with spacing. Pretty good. They got it and appointment within like 3-4 days. But I send them back for wound checks here until they take it out of appointment.
Remember too that most hospitals have hyperbaric chambers. They're just not burn centers. But if you have to dive somebody due to CO2, most hospitals have carbon monoxide. Most hospitals have them.
There's something I added, this is a pro that everyone needs to know. It's on the boards. It's definitely something you need to be working in a non-burn center. So these are just the transfer criteria for burns. So partial thickness over 10%, burns involving the hands, feet, genitalia, perineum, major joints. Full thickness, any full thickness burn, electrical, chemical burns, and inhalation injury, any complex comorbidities, concomitant trauma, pediatric patient, non-pediatric facility, and then any special social, emotional rehab intervention requirements. these are just the general recommendations. You can transfer, I think, without any question, any patients that meet these criteria. I would recommend talking, you're going to probably have to talk to the burn physician or the fellow and work with them in terms of that. I think they see a lot of these. You can send them pictures of the actual burn and to see if they actually need to be transferred to the hospital. And it's not because it's a pain for them, but it can be a big pain for our patients as well. If they get transferred to another institution and they really just look at them and say, you're okay, you can leave. But obviously you should call the burn center and consult with them for anything you're concerned about. Anyone have a preference on burn center they use? Faculty?
Staten Island is good, and I also think Cornell has good burn.
Yeah. I often ask my patients, I feel like we deal with this more in pediatrics than anywhere else. I often ask the patients if they have a car, Staten Island is easier, and if they only can travel by public transportation, a lot of times Manhattan or Jacoby is easier.
Well, the fact that there's a Brooklyn clinic for Staten Island, and they always answer the page. If you call them any time of the day, Cooper is really nice. They're really, very helpful. They'll give you a lot of information. I found them to be awesome.
Yeah. But it can be difficult to get to if the family doesn't have a car.
I recently transferred somebody with burns to the scrotum and to the posterior thigh to Staten Island, but they were rejected from Cornell. So, but we really thought that they should go to a burn center. So I think if you really feel like they should go to a burn center, try out a burn center.
Good. Yeah, that's a good.
The other thing, if you're at Kings County, they really want you to transfer to another HAC facility sometimes, so they'll push you to send us to Jacoby. But if, if you can't get them in there and if the patient